We're going to talk about mental health and how we can better bring mental health into direct primary care practices. And just a little bit about a background on me, and then I'll let Arielle tell a bit about what she does, and then we'll kind of have a discussion on mental health and how to bring it into primary care. As a pediatrician, there's a lot of mental health issues that our children and teens and families are facing. And when I was starting my practice, it was something that was really important to me is how can we support those families and those children and adolescents with their mental health issues and have it feel like part of the family, like part of the place that they go to for both their physical health care and their mental health care. And so I kicked around a lot of ideas. I asked in a lot of Facebook groups, like, what are people doing? And what we've done is I'm going to talk through kind of all of the different ways that people tend to integrate in direct primary care. But what has worked for us and has just been the best collaboration ever is there was a therapist in town who was ready to start her own practice. And we said, well, let's co-locate. So we, go in the same door, and our exam room are on one part of the hallway, and her therapy rooms are in another part of the hallway. And what that's allowed us to do is to collaborate with a lot of our patients. She has her patients, we have our patients. There is some overlap of the patients where some of ours will see her, some of ours will see other therapists, and some of hers will go to us for their primary care, and many of them will go to their regular pediatrician or family doc for their care. But what it's allowed for us is to really quickly get patients in when they need it. And it's really allowed us to collaborate and talk through some of those challenging patients where instead of, I don't really know what's going on here, I'm going to send them out and I hope that they can find somebody, or I print off a sheet and give them some names and cross my fingers that in 3 months or 6 months they've gotten in, because they, hey, do you have time? Can we talk this through? Can you just kind of eyeball this patient and give me a sense of what you're thinking on them? And it's been a really beautiful collaboration, and she's actually grown her practice faster than we have grown my practice. She started as a solo therapist, and now she has 3 other therapists that work with her. So we're about landlocked when it comes to space because she has several therapy rooms within our space that she uses, and it allows us to collaborate. And so, Arielle, can you tell me about your mental health experience and how that has really shaped what you do now at Bruin Health?
Yeah, thank you so much, and I love the approach that you've taken. I think that would be my ideal for every single clinic, to just co-locate with a specialist. So I'm Arielle. I have my PhD in health psychology. I spent a lot of time in the research world learning about and studying how our mental and our physical health are inextricably connected, right? We cannot separate these things out, even though, as we all know, our healthcare system treats everything going on up here as somehow separate from our bodies, which makes literally 0 sense. And it's really primary care that's feeling the brunt of that, because you cannot access the specialists that you really need to be able to provide that high quality mental health care within your practice. So with Bruin, so I co-founded Bruin really to solve that specific problem, is really trying to enable primary care doctors to provide high quality mental health care within their practice without it feeling like this thing they're just sending patients out to, because I think from a patient's perspective, that feels like you don't think mental health is part of my physical health.
Well, it almost feels like you're giving the patient homework, and then,
yes.
I've talked at length about how self-scheduling is so beneficial for DPC practices because I, as a patient and a healthcare consumer, my wife has been telling me that I need to get this spot right here on my face looked at, and I have to call the dermatologist. And so it's going to add like 3 months to me actually calling them
yes.
to get that to happen. And it feels like very similar in the mental health space of, hey, here are people that we typically send to patient, go find somebody. And especially in the DPC relationship and the way that we care for our families that we're entrusted to serve, it feels like you're kind of like, yeah, just go see if any of these people are available and if they take your insurance or if they have availability, and then let me know. And I think that we want to do better for our patients than just pushing them out with a printout of different therapists that might be taking people.
And that's asking somebody who's depressed to do that, like somebody who is struggling.
Right.
So this statistic is very sobering, but only 10% of patients referred in that way will get one visit with a specialist.
And that's scary too.
Yeah.
When you think about the downstream ramifications, the acute and chronic ramifications of those unmet needs.
Exactly.
And so I think one of the things that we really talk about and try and emphasize, and I feel like the pandemic has really helped at least bring mental health discussions into the mainstream and make it more acceptable and not something, not a stigma, is mental health care being a holistic part of the health care for patients.
I totally agree. And I think that the way that we do that in practice is by treating mental health just like we would any other physical health condition. So that's really one of the main motivations for us with how we decided to build Bruin is if you suspected that a patient was experiencing any other condition, what would you do?
Right. If you thought they were having a heart attack, you probably wouldn't give them a printout of cardiologists that they can call and see if they have availability.
Yes. You also probably would, I don't know, do some testing, collect some information, try to understand why they're experiencing the chest pain, right? You wouldn't say, I think you might have a mental health problem, you should go talk to a therapist, right? Like, I think that in order for us to really start integrating mental health into physical healthcare, we need to treat it like it's any other healthcare condition, which means we would order tests. We would understand why this person's experiencing these symptoms, and we would actually try to get to the root cause of why that patient's experiencing that, and then select treatments based on that root cause. And that's why I love working with DPC, is that's exactly what you all do. You're not treating symptoms here. Like, you actually want to understand what's going on with your patients. And I think that you have a really unique opportunity to do that with mental health.
Well, I think it's something like we want to set ourselves apart in DPC, and I think that mental health is a really good way that you can set yourself apart. We have this, and it's not a silo. It's not something where we work totally separately and we have no idea what's going on, and you do your thing in the mental health sphere and I'll take care of the physical health sphere. I think that's something that you can really use to differentiate yourself, because patients are very wise to how their mental health affects their physical health. And I think that is something specifically that the pandemic has really brought to the forefront, is stress and anxiety and depression and all these different things that patients are facing. If they feel like, okay, my doctor and their practice is going to be looking out for my physical health, but they're also going to be looking out for my mental health and treating it as one, then you're going to see, okay, this is kind of different. This is not really what I was expecting, because at my previous practice where I was at, they kind of just talked about the physical health, and if you had mental health questions, they told you to find a therapist or counselor or something. You, as a DPC practice, can differentiate yourself by having mental health as a main part of your offering.
Yeah, and I guess just to add to that, something that I was really inspired by with what Zach was saying during his keynote was that we're really trying to redesign healthcare with DPC, right? And I think something that drives me nuts is the fact that we have this separate, siloed mental health care system that's extremely fragmented. It's serving nobody. Patients and providers can't access it. And I think with DPC, you have the opportunity to actually do it right. Like, actually have real integrated care and not treat mental health as this separate entity.
Right. I think one thing, we were talking over lunch, and somebody was like, well, why would somebody that has an 11-year-old or a 13-year-old sign up for a pediatric DPC when their kid, maybe they get strep throat once a year and they don't come in? One of the differentiators for us is we actively surveil for mental health issues. And that's one of the reasons that people sign their teens up for us, despite the fact that they let's be honest, they don't come in that much, is we every quarter send out a mental health screening. Is your child anxious? Is your child depressed? The child fills it out on their phone, sends it back to us, and then that gives us the opportunity then to intervene early. And I think a lot of parents realize, oh yeah, like the 12-minute visit with all the forms for the summer physical, that's the only check-in when it comes to mental health, when summer is, a time when they probably have, by and large, less mental health concerns in the school year. Well, this practice, yes, we don't see them a lot, but I know that they're actively trying to make sure that my child doesn't fall through the cracks and get more serious before we're able to intervene when it comes to their mental health. And so tech has really catapulted mental health availability and the ability to take care of mental health issues in a lot of different ways. Could you kind of walk through some of the ways that tech has enabled better mental health care?
Yeah, I think, kind of digital mental health 1.0 over the last couple of years has been really laser focused on access, which is amazing. So now you have all these telehealth platforms that are available to you, telehealth platforms that are making it easier for therapists to get reimbursed by insurance. We also have really cool virtual specialty care for things like OCD, for ADHD, and for PTSD now as well, all insurance-based, like very targeted treatments. So I think the problem is, and then not to mention all the digital apps out there, there's so many. I think the problem is like, how do you leverage all of that? Because like, how do you know what's evidence-based, what would actually be good for my patient? You don't want to pick one necessarily, because that's not going to service your entire panel. So I think that's the first wave, is really focusing on access, which is incredible. What we're focused on at Bruin is really, how do we use technology to bring specialist level knowledge into your clinic, such that you don't have to necessarily hire a therapist or a psychiatrist or a psychologist in clinic to service mental health. I think that, like what I said, in an ideal world, everyone would just have that in their clinic, but I don't think that it's necessarily feasible for everyone, especially folks who are practicing in more rural care desert locations where they are de facto mental health, to do that. So how do we equip you with the ability to actually evaluate your patients thoroughly and select the most appropriate treatments for that patient when this isn't your level of, you're not mental health experts. I think you want to be, which is fantastic, but just like anything else, you're probably spending a ton of time reading online, maybe like scrolling through Psychology Today, trying to find therapists for your patients, which is a lot of work. So I think that's how we're thinking about leveraging technology.
I think it's great that we have so many options. And I wanted to run through, I've been seeking the wisdom of all of the Facebook groups and everything like that to try and distill down what are DPC practices in 2024 doing for their mental health. And to take a page from Dr. James's talk yesterday on AI, I asked it in the Facebook group, and then I just selected all the text, and it was a huge jumbled mess. And then I plugged it into ChatGPT, and it made 7 different categories for me of ways that practices are integrating mental health into their care. And so I'm just going to run through those, and then we want to leave a lot of time for questions, because I'm sure that there will be a good number of questions about mental health and how to integrate it, or how different practices have done it. The first is in-house, and there's a lot of practices that will hire a mental health counselor, therapist, psychologist to have as part of their DPC. Some of them it will be included in the membership. Some of them it will be limited to a certain number of visits. Some of them will have it be a separate fee if they want to access it. And there's a lot of practices in the country that are doing just that, which is hiring it to be in-house. In the same realm is they're hiring coaches or health supports. And I think that is a great way, especially if it was a specific condition, diabetes, any of the different things, ADHD, something along those lines, where there may be a benefit to having a coach as part of the team, and then making sure that we understand the role of a coach versus a therapist in like distinguishing that and making sure patients understand that. There's different apps. BrainTap is one that I heard from several as different kind of innovative ways to try and work through some of those mental health issues. Another was groups. So instead of doing one-on-one, they do group support. One, because it brings them into the practice and it allows them to service more patients. They can bring in a therapist to do group support for whatever specific condition as a way to get those patients some access, some support to not feel so alone. And then the typical, which is the external and collaborative approach. So it would be either referring to an outside office, hey, I really think that you should see this person, call them and make an appointment, or we'll call them for you to see if they have availability, make appointments. That would be an external kind of typical sort of referral. And then also referring, which is what we do, to our external organization that is on site. So they're collaborative in our practice in that we share the same space, and so we can easily refer to that practice that is uses the same door to come in and everything along those lines. And then the next was tech-enabled, and several people in the DPC groups had mentioned Bruin, and maybe you can just give us a little bit more on that while we're on that topic, and then the last one, and then we'll open it up to questions.
Yeah, so Bruin is a tech-enabled service that allows primary care doctors to order an evaluation like you would order an x-ray or lab work to try to understand at a deeper level what's going on with your patient. So that actually is a fully automated evaluation that patients can take at home, which is fantastic because not everybody really wants to go talk to another provider necessarily or wait several months or pay $500 to do that. And then based on that assessment, we're able to create a report that goes over likely diagnoses. We explain why the patient's experiencing their symptoms, so that gets at root causes. And then we'll actually come up with a care plan for that patient based on what's evidence-based. And then from that, our care coordinators are able to actually connect your patient to resources and providers that they have access to. So because we're not the ones providing care, we can leverage whatever is evidence-based and clinically relevant for your patient, but also practically speaking, what they can actually engage with. So all those tech-enabled like virtual care platforms that I was talking about, we can leverage those if there's a care desert, or maybe your patient wants to go in person at night and have it be covered by Aetna. Our care coordinators will find somebody for them.
So the thing that I like about that and similar platforms is that you know where it's going next, and it's not the nebulous here's the list, call and see what you can find. You get the evaluation, and then you're able to move forward from there.
We'll also actually monitor your patient over time and reevaluate them to make sure that the treatments are actually working, and we give that information back to primary care so you can really quarterback their mental health care.
Awesome. So that was the sixth one. And then the seventh one was just the way that we as primary care doctors are able to work and help with our patients where we have them in the exam room. And so doing those check-ins, both the screening, the mental health screening, and then the checking in with them, finding out what's going on in their life. I think DPC, we care a lot, and we also get to know our patients really well. So we have a much more broad sense of what our patients are facing, the context of their life, and all of those ways that their life affects their mental health. And then the one thing that I mentioned that we also do is kind of the automated check-ins, where every quarter we're sending it out so that we can do some mental health screening for our adolescents and teens so that we're not getting behind and letting things build up. Were there any other big ways to differentiate or ways to integrate that you're aware of that we didn't discuss?
The only thing that I will add, it's not really integration, but just differentiation, is I think right now our mental health care system is extremely reactive. We really wait till somebody's in crisis. And you guys have such a unique opportunity to provide unprecedented preventive mental health care, which I don't think exists in this country. And so I think by getting out ahead of it and just making this part of routine clinical care, it's a really unique opportunity to, one, destigmatize mental health, and two, to really kind of help patients do things now while they're not in a crisis that are going to help build up resilience and buffer them from potentially experiencing mental health problems down the line.
Well, I think for me, before I was in DPC, it's always like the elephant in the room that you're not sure if you have time to rein back in of okay, we're at our physical, we got to get our shots, we got to get our height and weight and talk through all these different things. If I bring up mental health, am I going to be derailed for the next 3 hours? And how am I going to get these patients back at a different time to talk through their mental health issues? And now, when we have longer appointments and deeper relationships, we can have the time to ask those questions. And then, rather than being reactive, saying, one thing that I will do with teens often is okay, it sounds like you've got a good handle on things now. What would you do if it started to get stressful, or you got overwhelmed between dance, piano, and your rigorous studies and all those sorts of things? What would you do? Let's talk through that and do a little bit of proactive counseling, which I would have never had time before or even felt comfortable with my skill set. I've had the time in DPC to kind of develop some of those muscles that previously I didn't have. Mm-hmm. So with all that being said, I want to open it up to questions. We'll have somebody run around with the mic, but any questions on ways to integrate mental health, what works, what doesn't work, or just comments about what you have done in your practices for mental health?
Hi, I was wondering how you do the model, if you were gonna combine it with your DPC fee, okay, you do one or for a year or something like that, and cost-wise, how you would do it?
Yeah, I'll speak to my part, and then maybe you can talk about how that could possibly work with Bruin too. We don't do that in my practice, but I do know that there's some practices where they have a counselor that's available for the patients, and they get a set number of visits, and they bundle that in. So you can expect that not everybody's going to use it, or not everybody's going to use it at any stage. So we're going to add $5 per month to the membership fee for everybody to pay for a counselor that's available for 2 sessions to talk through what you're facing. And then if you have ongoing needs, we have packages and those sorts of things. I think that's how I would set it up. I don't know if anyone else does that or has any thoughts to share on that, but I feel like that is how, if I was going to integrate it in, I would do it so that we're able to offer that. And I think that would be a real differentiator. I know of another panel that they have essentially they've partnered with a EAP, an employee assistance program, to get all their patients on this EAP. And it was because they just knew the EAP owner, and he was able to extend it to their panel, and they are able to get, for some small PMPM, all their patients can access a certain number through the EAP rather than their on-site counselor. What other questions? Oh, sorry, and before we ask the next question, how would you say a DPC practice could integrate like a tech-enabled solution like Bruin with their panel?
I think it depends on the pricing model of the tech-enabled solution. For us, we're really kind of like a fee-for-service model. It's really, a set amount of money for every evaluation and episode of care coordination that we do. So depending on how you want to price that, I mean, what's nice about DPC is you can do whatever you want, right? So you could either eat the cost of that because it's software, so it's relatively inexpensive, and you could just provide that as part of the care that you give. Or you could pass that cost down to your patients like you would any kind of lab work or medications. And if you wanted to, I've heard of doctors doing kind of like a cost plus model, because obviously it takes time for you to review the results and kind of act as that specialist. So if you wanted to make it be more of like a revenue driver, you could also think about it like that.
Hi, thank you for including this in this conference, because this is such a need, especially in the pediatric space. We've also integrated a mental health counselor in our pediatric DPC, and we found, an idea for everyone, we found that, I'm sure my therapist would speak to, that it takes more than just 2 visits to really crack the shell of a child, and I'm sure that's true of adults as well. And so to make it a little more palatable for parents to kind of follow up and do more than 2 sessions, we just bundled 6 sessions at a time. And we found that after that, a lot of them wanted to do more of like a monthly maintenance. And so it kind of just created this humming machine of incoming patients for therapy. Because I think after the first 2 sessions, they're a little bit like still uncomfortable and don't necessarily want to come back. And so when they're committed to 6 sessions, they're like, oh, I actually kind of like this. So just an idea for people.
That is exactly how we do it. I mean, our therapists typically do either 5 or 10 sessions, and then what that does is they have made a commitment, and they know it's available to them, and they don't have to keep remembering, and we'll make sure that they make their appointment before they leave so that they have that. And then they often do keep coming. Even when things are in good shape, they'll check in, they'll come on a regular basis kind of for that like maintenance. And for kids, I mean, they're always learning, growing, and experiencing new things. And so there's always the opportunity for them to learn new skills, even if they're at a good place. And I mean for adults too, like who couldn't use the check-ins and, okay, things are going well, let's add some more tools so that when something pops up, you're ready for it. Other questions out there? It's hard for me to see, but I see some hands.
Hi, thank you so much for bringing this up. This is such an important topic. I don't know if the audience knows this, but 11% of all ED utilization is for depression and mental health. So thank you for bringing this up. We are running a behavioral health company, and we're really excited about potentially partnering with DPC. But I'm curious, we know that with the higher demand for mental health the costs are also driving up, and we believe there is a trend to potentially seeing behavioral health as direct behavioral health. I wonder what your thoughts on that and how behavioral health specialists can effectively partner with primary care, direct primary care, to drive the most impact at a in a cost-effective way.
So when you say direct behavioral health, do you mean that it would be a membership model or a cash pay model, or can you just expand on that a little bit?
Yeah, so normally, private practices for behavioral health are charging $300 per session. We believe that to increase access and increase quality of care, there needs to be a change in that model too. So we believe that there might be a subscription model in the future, and that could be well integrated into the DPC practice. So we're trying to find out how we can better collaborate with DPCs to make sure that cost is still like the treatment that we're providing is still cost effective and goes well with the DPC practices.
Yeah, I mean, I think that there's definitely the opportunity to grow the direct behavioral health and have some sort of membership or something along those lines that's a lower cost, higher touch point when you don't have insurance. I mean, that's what DPC is. Why couldn't there be something for behavioral health along the same lines if we're saying that mental health is healthcare, that should be something that does exist and that people subscribe to and realize? I think one of the challenges is the episodic nature of the mental health issues, and sometimes the acuity of the mental health issues can make it difficult for patients to recognize the need to have that monthly membership fee where some months are good and you don't, you have to somehow justify the cost and the value that you can offer. And I think we've done that to some extent in our practice by doing frequent mental health workshops. So we are teaching about mental health issues for our patients, about ADHD, about anxiety, about different things, and giving them tools, and they get access to that as part of it. And so I think that would really be the way, is to provide the mental health care, but then provide lots of touch points outside of those actual visits that justify the ongoing membership cost for direct behavioral health.
I would also just add to that, we do see that model in very large national teletherapy companies. I think you know what I'm talking about, so I'm not going to name them by name. And I think that DPC works because this is clinician driven. And so I think for that to work, it would need to be like grassroots, right? Like therapy practices choosing to start that model and defining it for themselves and then partnering with DPCs versus having like a corporate entity, trying to derive as much value from therapists as they possibly can in that model.
Hi, my name is Vince. I'm a family doctor in a two-person direct primary care practice in Michigan. And earlier this year, we launched a sort of a direct membership program for mental health within our practice. And we're just playing around with it a little bit, but basically we have a 3-month or a 12-month option you can buy into. And then any member of your family can use the certain number of visits that you get within that. So that can be mom, dad, any of the kids, it doesn't really matter. And so when we were hiring therapists who work with us part-time, we wanted to make sure they had the skill sets that could address those various age groups. But our price point is about $110 per visit overall, which we think is fair and reasonable, and also just sort of baked into our practice, and our practice has gone pretty well. It sort of feels like for a lot of people that the barrier to entry is a little lower because we've sort of vetted them in the first place. I can't say it's been super successful so far. We're still trying to play with it, but this is our experiment to try to get into that space more meaningfully.
Well, I love the words you use there with experiment. And I think that's one of the things that DPC is great at, is we can run experiments and we can see how it works and where the places that it works and where it doesn't work and what people like about it and what people don't like about it. And I love that idea of a 3-month or a 12-month membership. Like, you're committed, but you're not committed forever. But you do know that you have this access point where then you're able to get that care and you can derive value from that during the time that you use it. And maybe you'll want to then keep it for more than the 3 months. But I think that's a great angle on.
And then offering it for any member of the family as well, and is something we thought would be important.
Yeah, I love that idea too of like, hey, I've been using my sessions. Maybe you should use your sessions too. One last question.
Oh, good, I get to go last. Jay Keese, Direct Primary Care Coalition. I just want to add my voice to echo what I'm hearing here. I mean, I'm really excited to hear the idea of the acceptance of the idea of integrating other behavioralists into the DPC practices. I think Garrison Bliss was at our meeting a couple of weeks ago and said that the foundation of DPC is trust. And part of that foundation is to know when there's a behavioral issue, which today is primary care, is beyond the scope and the ability of the physician that's handling that. And not to say that given the time and the energy and the love and the trust that you all put in, that your patients put in you and you put in your patients, that you can't do some of that. But this conversation is so important because to integrate behavioralists, licensed clinical social workers, and others into this ecosystem is so important. And on a public policy level, government, employers, others are screaming for this to happen in an integrated way. So thank you. And I just, any thoughts you might have on this idea of where that handoff is and how that goes and where to know this. But to Vincent's point, the idea of having services that you can bolt on to the DPC, I think you're going to find you're going to need them more often than not. And from personal experience in my family, we've used these services with these physicians and providers, and so important. And they've not really traditionally been part of primary care, and they need to be.
I echo everything that you said. I think that's so important. And I think that as a DBZ physician, you often want to just take on it all. And I can probably do that. I can probably do that. But it's really important to know your limits and have a good resource. And that's what I love about having our therapists right in-house, is I can say, I told them this, like I gave them some strategies and ideas that were like top level that I felt comfortable sharing, but I want them to see you to keep working and to gain more strategies and to keep going, and get more help than I feel comfortable offering. But it makes for a really nice, easy handoff, and then we're able to interact on a regular basis to say, hey, how's he doing? What do you think's going on? Do you think he has more, is anxiety driving this, or is this ADHD or trauma or something else? It's just been like the most lovely way to collaborate. So thank you all so much. If you have more questions, find me, find Arielle, and we can go from there. Arielle.
Thanks.